So I really wanted to kick off by thinking about some of the evidence base in the area, but I also want to, like a spoiler alert, and give you an answer, a straight, clear-cut, non-political answer. So is the gluten-free diet a risk? Well, yes, no, maybe, and it depends. As so much things in nutrition, unfortunately, it's context and the individual clients and patients that we're seeing. So I thought I'd start with some well-known evidence-based publications, The Sun and Reader's Digest, those well-known evidence-based publications. So this is some titles that we've seen in the press over the last couple of years. These are particularly related to studies that have been done in the last sort of couple of years. So they're talking about deadly diabetes and celiac disease and gluten-free diet, the risk of arsenic and mercury, and avoid the gluten-free diet if you want to avoid heart disease. So of course, as dietitians, what we really need to do is go back to the original studies, and these are the studies that have been related to those headlines. The interesting thing, I think if we go back to our friend, the hierarchy of evidence here, what we need to understand is these studies are all cohort and case series. They're all observational, and therefore you can't really establish causation. And the studies themselves acknowledge this. They talk about self-reported data, unmeasured confounding factors, observational nature, and cannot establish causality. And equally, they all make the point in summarizing their conclusions that this is due, really the risks are due to modifiable risk factors. So I think we cannot say the gluten-free diet is inherently a risk in terms of things like diabetes and cardiovascular risk. And what people need if they're on a gluten-free diet is they need good nutrition advice. And if there was only a profession where professionals used evidence-based information in a practical way, then we could help these patients. So obviously what I want to do is going back to a systematic review. I think this came out just last year, so it's fairly hot off the press, and it was looking at some of these issues in a bit more detail. So if you look at the glycemic response in celiac disease, there was 3 trials. The interesting thing about these trials is essentially they were all within the normal range. So there was no range above what we class into a pre-diabetic stage with the studies that's being done. And interestingly, I thought this was a very interesting study in type 1 diabetes and celiac disease. And what they found is patients with diabetes and celiac disease had less retinopathy. And they hypothesized the reason for this was those patients were adhering to the diet better. They had greater nutritional knowledge. So the idea necessary that a gluten-free diet, certainly in type 1 diabetes, would necessarily be a diagnosis that could cause further problems. It might actually have some potential benefits. Of course, we wouldn't want patients to have 2 diagnoses like that, but I think we need to have some nuance about how we interpret the data. In terms of BMI, there was about 6 studies, but interestingly, they were all within the normal BMI range. And I think this was a really interesting result from this study. What they noticed, they're comparing it to national standards in America. But what happened here is actually patients moved out of the underweight zone. So after a year on a gluten-free diet, there was less people who had a BMI of less than 18.5. And there was also less people who had a BMI of 30. So people who are underweight, they moved into the normal healthy range, and people who are overweight, more people moved into a healthy weight range. So again, I think it shows this nuance that we have to think about the data when we think about the gluten-free diet. Equally, blood pressure. There was only really one study that showed an increase in blood pressure, and I thought this kind of was worrying. It was only a small part of the cohort, but they did show almost a 4-fold rise in hypertension in celiac disease. And again, I think what this does speak to is it's important as dietitians, if we can liaise with our gastro colleagues, some patients may need medical follow-up, and we can highlight that and advocate for our patients in that regard. With cholesterol, there was quite a few studies in this regard, but only 3 showed a real increase. And interestingly, I thought this was quite interesting. All the studies reported a concomitant rise in HDL cholesterol, which obviously potentially protective. So to summarize this systematic review, they thought all the risks were modifiable. They thought the overall effect on individuals in cardiovascular risk remained unclear. We can't discount in celiac disease some element of the inflammatory response in celiac disease. Celiac disease is an autoimmune inflammatory condition, and some of these effects, cardiovascular, glycemic effects, may not just be relevant to the gluten-free diet, they may actually be due to ongoing inflammation. And obviously a consultant with a dietitian is essential. So I did want to talk briefly about micronutrient balance. This is a pediatric study. There's definitely some concern about micronutrients on the gluten-free diet, but I thought this was a really interesting study in patients 14 to 18. There's about 40 patients. And that red line is the line of dietary reference range. Now, there are some problems with intake here, but actually they were there present before the gluten-free diet was commenced. And a year later, pretty broadly, micronutrient status was pretty good. And equally in terms of macronutrient distribution between baseline and a year later, it was fairly similar. So again, I think this speaks to maybe in the pediatric population where children are under parental guidance, they're more likely to adhere. In terms of the microbiome, I think this is an interesting area. I'm fascinated for the talks later on from Bridget as well. So this was a classic study looking at the effect on the microbiome in about a small cohort, about 10 patients without celiac disease. But it did show a reduction in some of the beneficial bacteria that we would acknowledge, like bifidobacterium and things. Interestingly, though, what they also acknowledged was there was a change in the immunostimulatory effect, and the authors acknowledged that this actually may have a beneficial effect in some patients on celiac disease because it seems to be a microbiome-mediated reduction in the immune response. There was a more recent study. This is on a low-gluten diet, again showing a reduction in maybe some of the bacteria we would expect. But equally what they showed I thought was interesting in this cohort, which is slightly larger. So it wasn't a gluten-free, it was a low-gluten diet, but they showed better post-meal well-being, a better post-meal breath hydrogen production, and actually a reduction in post-meal bloating. And maybe this speaks to some of the symptomatic improvement in celiac disease is mediated by a change in the microbiota. But we have to be careful, and hopefully I can emphasize this later on, between improvements in terms of symptoms and reduction in inflammation in the small bowel. So I think we have to be careful when we're talking about that in celiac disease. This was an interesting study that's just come out, and I think what it's alluding to really is when we talk about the microbiome, particularly in celiac disease and the gluten-free diet, very difficult to relate studies to other studies and populations. The red patients in this infographic here are people with celiac disease, the yellow at risk, and the green with no CD. And what they're pointing about is between one population and another population, you may have different genetics, living habits, purchasing power, the diets may be different, age, sex, health status, time on the gluten-free diet. All these things may influence the microbiota. So they were making the point that individually and over time with variability, it can't be related from one study to the other. So I think we have to be careful when we think about that in terms of extrapolating things. So gluten-free diets, friend or foe. I don't know if any of you work in celiac disease, but if you work in Yorkshire, sometimes you do hear this. And if I had £1, but I actually think the products have improved in terms of palatability. And I wanted to highlight this study that was looking at the standard gluten-inclusive products versus gluten-free. And if we look at the dietary fiber one down here, we can see that actually the gluten-free products are actually higher in dietary fiber than the standard products. Again, with saturated fat, there's an improvement in the profile there. What you can see, though, is gluten-free products do tend to be higher in overall fat. And that's generally to improve the rheological and organoleptic properties. And I will give a free bottle of Henderson's Relish to anyone who can tell me what those terms mean at the break. Don't look it up. So some of the studies basically summarized that there was an interesting trend towards an improvement has emerged in the last 2 years in terms of the macronutrient distribution in gluten-free products. However, though, I think it's not just a straight story. This is a comparison of surveys of gluten-free products versus gluten-containing equivalents in terms of macronutrient distribution. And as you can see, there are some issues. Some surveys are suggesting lower protein, lower dietary fiber. So again, it speaks to the fact that what these patients need is proper dietetic support and advice. And I think part of the problems we see in celiac disease is summarized in this larger survey about adherence. It was done in Australia and New Zealand. And what it highlighted is actually, in terms of gluten-free information, patients weren't being seen by dietitians. About 40% had not seen a dietitian at all for any advice about a gluten-free diet. And only 24% had seen a dietitian with some speciality in celiac disease. And this effect was quite interesting. What they noticed is that when they rated people's knowledge of the gluten-free diet, so this is self-rating from excellent to terrible, what they found is all patients were excellent at identifying gluten-containing ingredients. But patients who rated themselves as a poor knowledge, they couldn't identify gluten-free ingredients. And the effect of this was over-restriction. Because patients didn't know what they could eat, they were over-restricting themselves. And again, they highlighted the point that what people need is dietetic support, and it's certainly not at the standard that we would expect. And that's why I'd encourage you to fill in the survey. So on balance for a gluten-free diet in terms of the scale of benefit, in celiac disease, it's a therapeutic necessity. So if patients don't follow it, there's an increased risk of bone mineral density, a small increased risk of small bowel lymphoma, increased autoimmunity and other conditions and hematological deficiencies. But I think obviously those are the problems versus these modifiable risk factors. So this is where things get controversial. So this is a little bit of an individual opinion about where I work locally, and I wanted to mix the pot and hopefully start a discussion. So with non-responsive celiac disease, this is patients, about 30% of our patients that essentially don't respond, primarily or secondary. So it may be that they get better then feel worse, or they never get better. Now, there may be various reasons for this. Now, I don't want to think about just straight non-adherence or refractory disease. What I want to think about is a subset of patients who are maybe super sensitive or acutely sensitive to gluten, or some patients who may have functional symptoms like IBS. So in that situation, for a super sensitive patient, we may need to look at a more restrictive diet, or for a patient with functional symptoms, we may need to look at a low FODMAP diet. But I think we need to be really careful in the celiac cohort how we apply this. So one thing to think about is I wanted to ask you a question. Now, I know at these things no one shouts out, but feel free to join in. Should we ever use a low FODMAP diet to treat a newly diagnosed patient with celiac disease? No? So I'd go with Dr. DeVito here. That's a no. So should we never use a low FODMAP diet to treat a patient with ongoing active celiac disease? So the situation is here, and this is a summary paper that came out. Ongoing villus atrophy can mimic IBS. So I think we need to be very careful. Celiac disease is an autoimmune inflammatory condition. Functional gut disorders, are obviously a disorder of gut-brain interaction, essentially. So I think we have to be careful about how we apply the use of the low FODMAP diet in celiac disease. And there are some shared pathology in terms of visceral hypersensitivity, dysmotility, low-grade inflammation, dysregulation of the gut-brain axis. And there's these two papers that come out of definitely highlighted the use of the low FODMAP diet for patients with ongoing symptoms in celiac disease. But it's very important to look at the methodology. So those patients were essentially, they had negativity of tissue transglutaminase and endomysial antibodies, and the other study used, again, negative tissue transglutaminase. So if a patient presents to you, and they seem to be following the diet, and they have negative serology, should we use, and they've got gut symptoms, should we use the low FODMAP diet in those patients? Well, my point would be, this is a patient, I couldn't believe this happened, this is a patient I saw yesterday in clinic. So this is a patient, she allowed me to share this, it's anonymized. And if you look, she has positive serology, elevated TTG and a weekly positive endomysial antibody. And her duodenal biopsy, no features of celiac disease are seen. The point is, you cannot rely on serology. This patient looks like she may be contaminating herself. The goal of treatment in celiac disease is essentially to have mucosal recovery. That patient has achieved the goal of treatment, but she has positive serology. We need to be very careful. This patient would probably benefit from a low FODMAP approach. So when we think about assessment, we're the gold standard, aren't we? If you look at all the papers, they will say we're the gold standards in terms of assessment. It's true. And occasionally some papers still spell our names wrong. I shouldn't complain. I've got dyslexia. I tend to spell things wrong. But I think this paper is a seminal paper in the area. So this was done down in Cambridge. And what it showed, this was the use of rebiopsy. Put to aside for the moment, a lot of patients won't want rebiopsy. When we do our celiac groups, I say, who wants a rebiopsy? No one says they want a rebiopsy. But this was an interesting exploratory paper. So they had about almost 400 patients, and 94% of patients had persistent villus atrophy. And dietitians were pretty good. In almost 70% of the cases, we could identify gluten ingestion. And after that, when they rebiopsied again, so these patients, some of them had 3 biopsies, there was an improvement of about sort of 44%. But about 55% had ongoing villus atrophy. And they concluded that dietary assessment fails to identify gluten sources in some patients. Now, I'm not having a go at dietitians. Serology is really poor as well. A serological marker in follow-up, TTG is great for diagnosis. Endomysial antibody, great for diagnosis. But TTG is not good as a follow-up marker in terms of response to the diet. So I think we need to be really careful. So what we think what we think on our centre is in selective, not all patients, but in a sub-selective patients. And again, as dietitians, we can advocate for this in joining in with our gastro colleagues. If there are patients who've got maybe positive bloods, no symptoms, ongoing grumbling, TTG and EMA, they may want a biopsy. The patients have got positive biopsy and symptoms, yes, they may need to establish a super sensitive approach. But a negative biopsy with symptoms then directs us to appropriately use these other restrictive diet, like the low FODMAP diet in celiac disease. And we've actually collecting some data here. This is some preliminary data. We don't have many patients at the moment, but what we've done is use biopsy to identify those patients that would benefit from a further restriction in terms of the low FODMAP diet. And our results are similar to sort of many of the RCTs you see around the world, about almost 60% on that sort of binary question, do you have adequate relief? Said yes. And when we looked at the sub-analysis in terms of abdominal pain and distension, again, it was very similar to the national, international data that you see. So we know it can work, but we just need to be applying it carefully in celiac disease. And one of the reasons I think for this is some brilliant work from Rosie Slatherly. I think Rosie's here today. She's given me permission to talk about her amazing data here. And she's done a lot of work about hypervigilance in celiac disease. So we know, yeah, a lot of patients don't hear very well, but again, there's a subset of patients for whom the gluten-free diet becomes problematic. You can't quite see it on this slide, but what Rosie is indicating, you should look for delusional beliefs. So I don't drive my car because I hear the airbag had flour in it. My husband used wallpaper paste in the living room, so I don't go in there because it may have gluten. And look for impaired quality of life. I couldn't go to my cousin's wedding because of the food. Staying at home keeps me safe. So these are all statements about patients' quality of life being really inhibited by the gluten-free diet. And we need to be aware of this in our patients. Certainly I've seen this in many, many patients, clinically, anecdotally from my clinic. Some patients, have said to me, well, I wouldn't use a piece of cutlery unless it's been through the dishwasher twice. We need to encourage sensible caution, but not hypervigilance. And I think there's that balance that we can hopefully be aware of as dietitians. Now, this is a controversial study, but I think it speaks to the application of someone who's on a strict gluten-free diet, who may potentially be hypervigilant. A lot of the patients who come to see us who are symptomatic, ongoing symptoms, they are the people who are often hyper-aware. So this was a study of the low FODMAP diet and looking at the risk of disordered eating. Now, SCOFF, the question they use, is validated for eating disorders. It's not validated in IBS. We need to be aware of that. But I think it gives us an indication. The higher the SCOFF score you have, this is 5 questions you can ask, the more adherent people were to the low FODMAP diet, the more likely they would be to have a very high SCOFF score. And even at baseline, 23% of those patients maybe had some risk of eating disorder behavior. Now, we've got to be careful. We know in the IBS population, if you say, do you think diet's controlling your life? That might not be a dysmorphobia or, an eating disorder. It might just be a facet of IBS and functional gut. But again, if you look at there, they say, do you worry, they're talking about, do you believe yourself to be fat when people say you were thin? And you can see in the adherent group, it was much, much higher than the non-adherent group. So I think this is it's only small data, we need more, but I think it's a signal that we need to be careful, particularly when we're applying the low FODMAP diet in a group of patients that are already restricted. So what about encouraging a nutritionally adequate and balanced gluten-free diet? It's easy. You just do this. So this is a bit of a summary. Now, I know obviously that's a really complex side, but I think it's highlighting the points about sort of early consultation with a dietitian. Let's get more dietitians. Let's try and canvass for more of us in gastroenterology and working in celiac disease. I think things like industry collaboration can be important in terms of the product development. Encourage pragmatic awareness. What I mean by pragmatic awareness is cautious restriction, but not over-restriction. And obviously ongoing follow-up and monitoring patients serologically in terms of their quality of life. And at the moment, in terms of the gastro specialist group, we're trying to develop some outcomes for celiac disease in this regard. And then it's what we do as dietitians. It's interpretation of the gluten-free diet to the individual in a way that meets that individual person. We're autonomous practitioners and we do diets best. And I think that's what we need to sort of tell our colleagues, our medical colleagues. So I did want to go on to another area of the gluten-free diet that I think has become problematic. And that's what I'd describe. It sounds like a pejorative negative term, but I can't come up with a better one, is what I would describe as lifestylers in the gluten-free diet. So these are people who are following it for whatever reason. They don't have a diagnosis. They may have celiac disease, but they've not been diagnosed. They may not have celiac disease, and they're following the gluten-free diet for all sorts of maybe spurious reasons. And some of you may have seen this before, but I'd like you to shout out. Do you know, is anyone who these people are? It's Jessica Alba, Brad Pitt, Gwyneth Paltrow, that well-known purveyor of evidence-based nutritional information, and Djokovic. So who do you reckon do you know what these people's dietary proclivities are? So obviously Jessica Alba, Gwyneth Paltrow, and Djokovic are all following a gluten-free diet. Does anyone know the diet that Brad Pitt follows? He's a... Really? He's a vegan, apparently. I was quite surprised, at least, that he was at one time. So the interesting thing is, this is an interesting study from a few of you guys outside of America, and what we're noticing here is there's less people who are undiagnosed with celiac disease. Brilliant. There's more diagnosed people with celiac disease. But also, we're seeing this rise in people on a gluten-free diet that are classed as PWAGs. Does anyone know what PWAG stands for? People without celiac disease avoiding gluten. It's never going to be a hashtag on Twitter. So we're seeing this rise in people avoiding gluten for various reasons, and I think we have to understand why. And I think this might be the video. I've got a little video that I think speaks to this. Hopefully, that may play.
Anti-nutrient? No, I don't.
What?
An anti-nutrient? I don't think I can answer that.
An anti-nutrient? I have no idea.
My guess for an anti-nutrient would be something that's in food that does not, that isn't nutritious to the body. It doesn't promote health. It just kind of gets in the way.
Oh my God, fries? That's the first thing that comes to my mind.
An anti-nutrient sounds like a directly counterproductive nutrient, like as is found in certain grains and other fake oils, trans fats, and other man-made hydrogenated nonsense.
It's hard to know what to say. Man-made fats and other hydrogenated nonsense. So I think we need to think about why this is the case. And the motivations to go for gluten-free are not symptomatic. Most people who go gluten-free without celiac disease are not having gut symptoms. And this was a really interesting paper that came out last year. And what it looked at is the reason. So most patients wanted to introduce inflammation or seek more natural ingredients or prefer not to eat grains or weight loss. And there was actually a disparity between millennials and non-millennials. I feel millennials unfairly get a hard time. What's wrong with avocado toast? But it was, it's more natural to improve athletic performance and all those things. So I think we need to be aware that most people, when they go gluten-free without celiac disease, are not doing it for symptomatic benefit. They're doing it because they believe it has these other benefits. So, and I think if we understand the psychological reasons behind this, there's this attribute of negative attributes to gluten, this desire to undermine biomedical authority and even diagnose others. And we know it ties into this idea of, managing any form of human malady with diet. If we eat the right foods at the right time in the right proportions, we can treat and cure anything. And we know that's not the case. Nutrition is very important, but there's a limit to its utility. So I think that's what this sort of study was pointing to. And I think as dietitians, the best thing we can do in this area is try and promote an evidence-based message. I'd encourage everyone here, if you're not, get on social media in some way. It doesn't have to dominate your life, that maybe it does me and Sean. But, get on there, get a Twitter account, and let's push an evidence-based message. So we know that the scale of the benefit in gluten-free for lifestyle is not there. It's based on the idea of chemophobia, weight loss, appeals to nature, and there is this risk, I think, in this cohort we need to avoid. So I'm very glad that you've listened to me. I do want to just have a spoiler, because what about the gluten-free diet beyond CD? Is there any patient cohort that we should use the gluten-free diet for? And later on today, we're going to have a robust and hearty debate around this. I'm really looking forward to it. I want you to all ask questions and join in. Don't be shy. And I'm more than happy to ask questions, but please make them easy.